Welcome back to the Deep Dive. We're always trying to cut through all that information overload, really get to the heart of things.
Absolutely. It's about getting beyond just the headlines, right? Finding those deeper insights.
Exactly. And that's what we do here, give you that shortcut to being genuinely well-informed, maybe find some surprising connections along the way.
Make things click.
Right. So today, we're taking a really important journey, I think. We're diving deep into the American healthcare system. Specifically, what it looked like before this huge initiative called the Transforming Clinical Practice Initiative, or TCPI.
Understanding that before picture is critical.
It really is. It's not just history. It shows you exactly why TCPI, why that kind of transformation was so desperately needed. It wasn't just a nice to have.
Oh, definitely not. It was essential.
And for this deep dive, we're leaning on some brilliant work. We're looking at excerpts from the book, The Agile Network.
Ah, yes. Great book.
It really is.
Yeah.
Written by an amazing team. Malaz Bustani, that's MD, MPH. Richard J. Holden, PhD. Jose Azar, MD. And Craig A., solid PhD.
A powerhouse team. And Dr. Bustani, of course, is a professor over at Indiana University. Brings a ton of real-world and research weight to this.
He really does. So our mission for this session, unpack those old complexities, the inefficiencies that were just baked into the system before TCPI.
Get under the hood of Healthcare 1.0, essentially.
Exactly. See what the problems were, why they stuck around for so long. It really sets the stage for understanding the massive changes that came later. So brace yourselves. Some of this might be quite eye-opening, especially the human side of it.
Yeah, the real-world impact.
Okay, so let's unpack this. And I think the best way in is through a story. A really powerful one that just lays bare the core problem. Let's talk about Tommy.
Tommy's story, it's quite something.
It is. Born in the 1920s, rural Kentucky. And this guy was sharp. A WWII vet, landed on Omaha Beach, D-Day +2, got a Purple Heart.
Wow. Incredible service.
Incredible. And after the war, he built a really successful life. Insurance agent, bank exec, entrepreneur, had a bottling company, a furniture store, built homes. He read the Wall Street Journal religiously.
Smart guy. Financially savvy.
Definitely. And he put that savvy to good use-funded college for all three of his daughters. And get this family set up. One daughter became a doctor, another an IT leader, the third a healthcare executive.
So intelligence, money, and direct family connections right inside the medical field.
Exactly. You'd think if anyone could navigate the healthcare system, it'd be Tommy, right? With that kind of support.
You would absolutely think so. And yet, his story really becomes the stark reflection of the system's flaws. So he's in his 80s, still pretty healthy, doing well, but he goes for one of those free ultrasound screenings at his church, I believe.
Yeah, the church. A friend had recently had a stroke, so it was, on his mind. Understandable.
Totally understandable. And the results come back from this mobile unit, and they tell him, point blank, significant carotid artery blockage. You need surgery.
Urgent surgery. Right then and there. And Tommy, well, you can imagine, fear kicks in, plus, the authority of the screening. He decides, okay, let's do it. Let's do it now.
It's an immediate decision.
But his family, especially his daughters, the doctor, the executive, they were really worried. They were pleading with him, Dad, get a second opinion. Go to a bigger hospital in the city.
Right. They wanted him assessed properly.
His anesthesiologist daughter even said, look, I'll pick the surgeon myself. I'll be in the OR with you.
Yeah.
His son-in-law, the brain health scientist at a big teaching hospital, he backed them up.
All this expert advice right in the family.
And Tommy, he said no. Declined their advice, went ahead with the surgery recommended from the church parking lot screening.
And here's the really fascinating and frankly tragic part. The piece Tommy wasn't told. Or maybe the system just failed to deliver.
What was that?
Well, the actual clinical guidelines at the time, they did not recommend surgery for someone like Tommy. No symptoms, no other major risk factors.
Seriously, so surgery wasn't the standard of care?
No. The evidence-based approach would have been, more tests, maybe some medication. That would likely have given him just as good, if not better, outcome, but with much, much less risk than major surgery.
Wow.
It just perfectly illustrates the problem, doesn't it? Even with money, smarts, a family full of medical experts, he couldn't get the right guidance from the system itself. His family tried reason, evidence.
But the fear, the way that initial screening framed it.
Exactly, that choice architecture, as they call it. His friend's stroke, that free ultrasound, it just pushed him down one path. Availability bias, recency bias, it overrode everything else.
And sadly, the family's fears, they came true. After that first surgery, Tommy developed delirium, undiagnosed delirium.
Which is a huge complication, especially for brain health.
Huge. It messed up his recovery. He even got readmitted for a GI bleed weeks later. But despite that major setback, they went ahead with the second surgery, the other carotid artery.
Oh, wow. They proceeded.
And guess what happened after the second one?
Let me guess. Another bout of delirium.
Bingo. Another round of delirium during recovery.
And you know, if we connect this to the bigger picture, it's just such a stark example of that gap. The gap between research, what we know, and what actually happens in practice.
It's brutal. It really is. Because here's the cruel irony. Tommy's own son-in-law, Dr. Bustani, his NIH-funded research was specifically on this, linking delirium to a 2 to 5 times higher risk of getting Alzheimer's within about 5 years.
No way. His own son-in-law's research predicted this.
Directly. And tragically, Tommy developed Alzheimer's within just 2 years of that first post-op delirium.
Oh, that's heartbreaking.
It speaks volumes, doesn't it? The scientific knowledge was right there in the family, but the system, the broader healthcare system, just wasn't set up to use that knowledge to protect him. The evidence was there, the application wasn't.
So his cognition starts to decline, and then things get, well, even tougher. The family starts getting these weird calls from the post office.
Yeah, about money. Large sums of money Tommy was sending to the Bahamas. Scammers.
Oh, no. And Tommy, he was in denial, right?
Complete denial. Refused any formal cognitive tests, even though his wife, sadly, had already been diagnosed with dementia herself. So Dr. Bustani, his son-in-law, had to basically make an informal diagnosis of Alzheimer's based on what he was seeing.
He did. And the family, they really tried to find a way forward that respected Tommy's wishes, his autonomy. Dr. Bustani had even developed this amazing collaborative care model for Alzheimer's back at Indiana University.
Something evidence-based.
Totally evidence-based. Proven to improve symptoms, ease the burden on caregivers, cut down hospital visits, and, crucially, help people stay home longer. Avoid nursing homes.
That sounds perfect. Why didn't they use it?
Because Tommy wouldn't leave his rural community. He felt he had, in his words, purpose, autonomy, and mastery there.
Yeah.
That advanced care model just wasn't available where he lived.
Another system gap. The best care wasn't accessible everywhere.
Precisely. And even with the data showing how good the model was, the way it was framed for him, it just didn't sway him. It shows how hard behavior changes within that kind of rigid structure.
So things kept getting worse with the scammers.
To the point where his daughters had no choice. They had to go to court, seek power of attorney to protect their parents' finances. Tommy was literally sending his life savings away, refusing to fund his own trust.
Good grief. What a nightmare for them.
And the court hearing itself was dramatic. While the judge was questioning Tommy, his wife's phone rings.
Don't tell me.
It was the scammers calling during the hearing.
You cannot make this stuff up. That must have sealed it for the judge.
Instantly. Granted the daughter's power of attorney. Later on, his wife had a fall, and that led to them moving into assisted living near their oldest daughter. Tommy eventually passed away peacefully in 2016, listening to bluegrass music, surrounded by family.
A peaceful end. But what a journey. What a reflection on the system.
Exactly.
So Tommy's story. It's not just one sad case, is it? It's what the authors, Dr. Bustani and his team, call Healthcare 1.0.
That's the label they put on it. And it fits.
It really does. Fragmented care, wildly different quality depending on where you were, old-fashioned practices, even misleading ads like that screening, medical errors.
And critically, no real incentive for doctors or hospitals to be proactive, to use the latest research, or to look at the whole patient.
Right. The system wasn't built for that.
Yeah.
So even smart, wealthy patients with doctors in the family like Tommy were kind of left to navigate this maze on their own, often unsuccessfully.
Left to fend for themselves.
And here's the kicker, the part that really hits home for me.
Yeah.
Dr. Bustani says this whole experience with his father-in-law, it was the single most impactful thing in his entire career as a doctor, as a researcher.
Wow. That personal connection, that direct experience of the system's failings, it's incredibly powerful, isn't it? It really fuels the drive for change.
Absolutely. It makes it real.
And that personal story, heartbreaking as it is, it perfectly tees up the broader historical context. Why was the system like that?
Well, you have to go back. Years ago, healthcare was mostly about acute stuff, right?
Broken bones, infections, things that happen suddenly. Exactly. Treatments were limited, people didn't live as long, so you didn't have huge numbers of people managing multiple chronic conditions for decades like we do now.
Okay, yeah. Different world.
So in that world, the fee-for-service model, paying doctors for each thing they did, actually made a certain kind of sense.
Right. You fix the bone, you treat the infection, you get paid for that task. Seemed logical.
It did. And it encouraged individual doctors to do lots of tests, maybe refer to lots of specialists, because each action generated a payment. There was no built-in reason, financial or otherwise, to coordinate, to collaborate across different doctors or over time.
But then everything changed. Over the last, 50 years or so?
Dramatically. We got amazing new technologies, incredible new treatments, and critically, people started living much longer.
Which meant more chronic diseases.
Yeah.
Diabetes, heart disease, Alzheimer's.
Exactly. A massive shift towards needing long-term management of multiple conditions. That requires coordinated, multidisciplinary care.
Yeah.
Teamwork. Long-term services, not just quick fixes.
But the system itself, it didn't change. It stayed stuck in that old model.
Pretty much. Stubbornly static. Still focused on those individual episodes of care, even when the patient's needs were continuous and complex.
Okay, I see the disconnect. The needs changed, but the structure didn't.
And the results, well, they were pretty bad, frankly. For patients, for the economy, care stayed siloed. Hospitals didn't talk to primary care. Specialists didn't coordinate.
Like the gaps Tommy fell through.
Precisely. And you still had costly tests and treatments being ordered. Maybe not always because they were truly needed, but because the incentive was just to do more. Volume over value.
Patients were left trying to figure it all out, connect the dots themselves, and pay for it all.
Yeah, leading to avoidable ER visits because they couldn't get timely primary care or maybe not getting crucial home care that could have kept them healthier. That fee-for-service system, it became, as the authors say, a noticeable and costly deficiency for everyone.
So the big question then is, if it was so obviously broken, so costly, why was it so hard to change?
That's the million-dollar question, isn't it? I think it boils down to inertia. A real reluctance, system-wide, to fundamentally re-engineer how things had always been done. Decades of habit.
Which brings us finally to the tipping point, the moment where change started to happen.
Right. The federal government basically said, enough. We need to reform the system. We need lower costs, but we also need higher value, better care.
And that led to actual legislation, right? Like MAC-Sure.
Exactly. The Medicare Access and CHP Reauthorization Act of 2015, MAC-Sure, that was huge. It started tying Medicare payments directly to quality and value, not just volume.
So paying doctors for good outcomes, not just for doing more procedures.
That's the core idea. Through things like MIPS, the merit-based incentive payment system, and encouraging participation in other alternative payment models. It was a fundamental shift in the financial incentives.
Okay, so the money started pointing in a new direction.
And building right on that momentum was the Transforming Clinical Practice Initiative, TCPI, which came out of the Affordable Care Act. This was meant to be a really big national push.
What were its main goals?
They were pretty clear and aimed right at the problems we saw with Tommy. First, push for payment and practice reform everywhere. Primary care, specialists, the works.
Okay, broad scope.
Second, really promote care coordination. Get providers talking to each other, breaking down those silos.
Essential.
Third, set up community-based health teams to manage chronic conditions better, closer to home. Think about Tommy's rural community.
Yeah, bringing the care to the patient.
And fourth, the big one, improve quality and lower costs by creating this whole collaborative network of hospitals, clinics, everyone all working together to support this transformation. It was ambitious.
Definitely sounds ambitious. How did they plan to actually make it happen? Did they have steps?
They did. TCPI laid out this vision with 5 key phases, a roadmap, really, for practices to move from that old fee-for-service way to becoming value-based operations.
Okay, what are the phases?
Phase 1 was basically getting ready, setting aims, building some basic capabilities for change, just getting started.
Makes sense. Dip your toe in.
Phase 2 was about data. Reporting performance, and crucially, using that data to figure out how to improve. Moving from guesswork to evidence.
Getting smarter.
Phase 3 was hitting the targets, achieving those aims of lower costs, better care, better overall health. That's the triple aim starting to take shape.
The core goal.
Phase 4 was reaching benchmark status, performing like the best top-tier practices.
Setting the bar high.
And finally, Phase 5, showing you can consistently deliver that triple aim better health, better patient experience, lower cost, all working together. It recognized this was a journey, not an overnight switch.
Right, a structured pathway for change.
And making this whole transformation work, well, required huge shifts. Managing care differently, thinking about whole populations, not just individual patients who walk in the door.
Like managing all the diabetics in a community, not just the ones you see today.
Exactly. And building what they called accountable health communities, where everyone felt responsible for the outcomes. Developing real teams, doctors, nurses, pharmacists, social workers, all working together.
Breaking down those professional silos, too.
Absolutely. And none of it happens without leadership that's willing to collaborate, to innovate, to constantly learn and adapt. Moving away from that old, rigid hierarchy.
So this whole TCPI framework, these phases, the focus on teams and communities, it really sets the stage for understanding what organizations like the Great Lakes Practice Transformation Network, which the Agile Network book focuses on, were actually trying to do.
Precisely. They were one of the groups funded to take this TCPI model, these phases, and actually implement them, turn the theory into practice on the ground.
Okay. So looking back at our journey today, wow. We started with Tommy's story, so personal, so frustrating, highlighting every crack in that old system.
Even with all his advantages.
Right. And then we zoomed out to see the bigger picture, the historical reasons for those systemic failures, the inertia that kept things stuck. It paints a clear picture of why change wasn't just needed, it was imperative.
It really does. It underscores just how big the challenge was and how ambitious something like TCPI had to be to even begin to tackle it. It wasn't just about tweaking things. It was about fundamentally changing how care is delivered and, importantly, how it's experienced by people like Tommy.
Yeah. Building a system that could actually learn, adapt, and maybe finally put the patient truly at the center.
That's the goal, a continuous learning health system.
So this deep dive has really laid bare the complexities, hasn't it? From the individual struggle to the massive systemic forces. Knowing all this, knowing the history, the challenges that drove TCPI, what does that tell you, our listener, about shaping a better healthcare future, a more agile, more patient-focused future? Something to think about.